Hello, my name is Ethan Schilling. I'm on the board of the Raymond A. Wood Foundation as well. And I have the pleasure of introducing Dr. Julia Crowley, who is our next speaker. Dr. Crowley is a pediatric endocrinologist and assistant professor of pediatrics at the Children's Hospital of Philadelphia. Originally from Virginia, she completed her undergraduate education at the College of William and Mary and medical school at Virginia Commonwealth University. She completed her pediatric residency at the University of California, San Diego. Recently, she finished a pediatric endocrinology fellowship at CHOP. She has continued on at CHOP as faculty working in the neuroendocrinology clinics. She also works with Dr. Shana McCormick on clinical trials related to hypothalamic obesity, including studies looking at non-alcoholic fatty liver disease in craniopharyngioma and setmelanotide use in hypothalamic obesity. And I'll turn it over to Dr. Crowley.
Awesome. Thank you so much. I want to thank Amy and everyone at the Raymond A. Wood Foundation for inviting me to speak today. This is going to be chill, and we're going to talk about adrenal insufficiency, starting with frequently asked questions that we often get from our patients. And then at the end, we'll do a demo of a Solu-Cortef injection. So I know you all probably have personal experience, and you learned from Dr. Alter this morning about Pituitary 101, but I just wanted to start with some basics so we're all on the same page. So the first question is, what is adrenal insufficiency? So adrenal insufficiency is a condition where the body is not making enough cortisol or stress hormone. This can be from a variety of reasons, but in our patients who have pituitary brain tumors, this is usually what we call secondary adrenal insufficiency, in that their pituitary gland is not sending the signal to the adrenal glands in the abdomen to make cortisol. And that signal is something called ACTH. So ACTH is supposed to talk to the adrenal glands so the adrenal glands can make cortisol. And this hormone is essential for life. It does a lot of things, including supporting our blood pressure and our blood sugar when we get sick. So on any given day when we're well, we need a modest amount of this hormone, and it circulates throughout the day based on a circadian rhythm. So when you wake up in the morning, that's when your levels of cortisol are the highest. They fall throughout the day, and then in the middle of the night, midnight or so, you have very little cortisol in your body. It rises again when you wake up, and that all goes around. When you're sick and need more of that stress hormone to support yourself, levels go up all the time throughout the day. So you might have hear us talk about different diagnoses of adrenal insufficiency, and there's two words we use. We talk about complete adrenal insufficiency, and we talk about partial adrenal insufficiency. So if someone has complete adrenal insufficiency, either based off their lab testing or the characteristics of either their tumor or their surgery, we make the assumption that they don't have enough cortisol both when well and when they're sick. And so in those people, we give them a daily hydrocortisone dose, which is cortisol. They take a small dose when they're well, and they increase doses when they're sick. Sometimes we make another diagnosis called partial adrenal insufficiency, and that is a diagnosis where we think you probably make a little bit and you make enough for your everyday life, but when you're sick, your body's not going to mount that response to make enough to respond to an illness. So for those people, they don't have to take a medicine every day, but they take a medicine when they get sick, larger doses of hydrocortisone throughout the day. So that's just to kind of orient us. Now I'll get to some of the questions that both our nurses in the neuroendocrine center and Amy sent me that have been common questions. So the first question is, if a child is fine but has a stomach ache or a touch of diarrhea and no fever, do we need to stress dose them or not? So in this situation, I would say you don't need to give stress dose steroids to your child. You do need to keep a close eye on them because the situation could evolve. So in general, indications to do that higher dose of hydrocortisone or stress dosing There's black and white situations that we can all read on a piece of paper. If your child's totally well and doing well, they probably don't need their stress dose medication. But if they have clear indications of illness, so we usually say fever over 101, a known bacterial infection, a broken bone, something that's causing severe pain, those are kind of the black and white situations where it's a slam dunk to give stress dosing. Sometimes there's kind of that gray zone where your child may be getting sick, they may be complaining of sore throat, maybe they're having intermittent low-grade fevers. In that situation, you should definitely talk to your doctor or the on-call team in your hospital. And over time, you'll kind of get to know your child and get to know what works best for them. In general, giving stress dose steroids for short term and intermittently should cause no harm to your child. If, we know kids get frequent colds. If you're giving stress dose with every cold, that could add up and lead to higher doses of steroids than we like. So something to be thoughtful about. But if you're ever in that gray zone where you're really questioning, probably does not hurt to give it. But talk to someone for some advice. What situations, so the next question is, what situations would stress dosing potentially cause adverse problems? So like I said, if you're giving stress dose steroids too much, that's a high level of the steroid that the body doesn't need all the time. If you're giving that all the time long term, you could have adverse effects on your body composition. So you could have increased fat mass gain. You could also have adverse effects on your bone, but like I said, that would be chronic stress dosing. Another situation is if you are giving stress dose steroids and your child also has diabetes insipidus. It's important to watch their urine output trends and know that stress dose steroids can make diabetes insipidus more severe and worse, and it can change kind of the patterns. So sometimes when someone's receiving stress dose steroids, they either need more water or more DDAVP, and in that situation, you should talk with your doctor to work through that. So moving on, the next question was, what is an adrenal crisis? How fast can it happen? So an adrenal crisis is a situation where the body does not have cortisol and the person's becoming critically ill. And usually there's an intercurrent illness. So there's a virus or bacterial infection that's caused stress on that person. Sometimes it can just be from withdrawal and missing doses of the cortisol, but usually it's associated with an illness. Symptoms of adrenal crisis would be feeling really lightheaded, dizzy, weak, changes in consciousness, passing out, and vomiting, especially prolonged vomiting. How fast can adrenal crisis happen? It could happen fairly quickly, but there should be signs that that's coming. And we really do think with watching very closely, you can keep your child safe in this situation. So vomiting and recurrent vomiting is something that should definitely be a red flag. So if a child vomits once and then kind of perks up and is able to take their oral stress dosing, you might be okay. But if they continue to vomit, that's when you would worry about adrenal crisis. You would resort to the intramuscular injection that we're going to talk about, and then call 911 and seek medical care. All right. The next question is, my son has been on cortisol or hydrocortisone for over 10 years. What are the long-term effects? So if we dose hydrocortisone like we want to at a low dose, that's what we call physiologic, just pure replacement of what the body should be making. We hope that there's no long-term effects of that. If you're getting a higher dose than what you need, you could see those issues with higher weight gain and fat mass and bad effects on the bone. But we really try to dose the daily hydrocortisone. We try to give the lowest dose possible, both based off your child's weight, height, and with their symptoms of how they're feeling, to avoid those long-term issues. The next question is, how long does a dose of hydrocortisone last? So as pediatricians, we really like hydrocortisone because it lets us replace steroids in a small dose, and it's rather short acting. So we think one dose probably lasts in the body from anywhere to 6 hours or so. Of course, different people metabolize it at different rates, and so it could vary between people, but on average, we think it probably lasts for about 6 hours. If your child, or if you're on prednisone, which sometimes our adult colleagues will use to replace this hormone, that lasts for about 8 to 12 hours, so it's dosed differently. And it's hard to dose a small child with that because we just can't get doses small enough. So the next question is, what would the recommended timing of the last dose of hydrocortisone be in the evening? So we give hydrocortisone usually twice a day, sometimes 3 times a day. And we know that in people without this condition, their levels of cortisol are quite low at night. And so to be the most physiologic possible, we would want to mimic that. So I would say the latest the dose should be given is 6 p.m. or so it can kind of be out of the body by midnight. In my personal practice, I dose the later dose in mid-afternoon, even a little bit earlier, like 3 to 4 p.m. You just have to make sure that works for the patient and for the child. The risk would be that their body, the hydrocortisone kind of like gets metabolized out of their body, and they wake up and they have symptoms of low cortisol, like morning headache, vomiting, those types of things. So as long as they feel okay, it is safe to give it a little bit earlier. The risk of giving it later, some people say it affects sleep and it can make them a little bit more wired. We also, kind of going off that, usually our morning dose is higher, and then the afternoon dose is a little bit lower to kind of mimic what the body should be doing. Next question is, what do you think about COVID and adrenal insufficiency? So I think COVID has evolved a lot, obviously, in the past 3 years, and and even so, our recommendations have been to kind of treat COVID as any other viral illness. And so there's no need to stress dose just because your child's COVID positive, assuming that they don't have the high fever and those other indications to stress dose. So if they're COVID positive and have a mild cold, you might get away with not being able to stress dose. The last question was, what about vaccines and stress dosing? And so a lot of people have asked that with the COVID vaccines. And in general, we don't think you need to stress dose before the vaccine. If you do get fever or symptoms after the vaccine that would meet the criteria, go ahead and stress dose after you get the vaccine when those symptoms do arise. I talked fast, but that was about half my time. And I think we'll do questions from the group at the end, correct? Okay. So the next thing I'm going to do is a Solu-Cortef injection demonstration. So I think what I'll do first maybe is do it with everyone sitting in their seats so the online people can see, and then we'll do it a second time. People can kind of come up closely to watch the demonstration. So I'm just going to get the supplies ready. And the rationale for doing this here is that if your child was diagnosed with partial or complete adrenal insufficiency, we assume you've been taught how to do this, but I'm hopeful that this is not something you're giving frequently. So it would be something easy to forget. So we recommend kind of keeping this on your radar, reviewing how to do it. I would say maybe once a season, so 4 times a year, kind of pull up a YouTube video. We have a great YouTube video through CHOP. If you just Google CHOP Solu-Cortef injection, and kind of review this once a year to know that you're refreshed on how to do this. So when would we give this shot? Whenever you're worried about an illness and your child's not able to take their oral stress dose steroid. So The two classic situations would be recurrent vomiting. So they vomit and they can't take their pills, and you're like, they're just going to keep vomiting. That's an indication to give the shot. And then the second situation is they're passed out and unconscious, and clearly they're not going to take oral pills. We recommend you giving the shot and then calling 911 and or your doctor for the next steps. But usually if someone's sick enough to need this injection, they're going to have to go to the ER and be evaluated. So in addition to reviewing the video seasonally, you should always double check your supplies and make sure you have what you need and that they're in the places that you need. So any places your child is, school, grandparents' house, ideally you should have the Solu-Cortef kit there. The things that you need with the kit would be, pulling it out. So this is the active vial. So this is where the medicine actually is. The medicine is the powder. So it's the Solu-Cortef or hydrocortisone. And then there's two chambers here. The higher chamber is full of saline. And so to actually give the medication, you have to press down and suspend the saline in the powder. So it's in a form you can give. So active vial is the first thing to have. Second thing to have would be needle. Third thing would be a syringe. And then alcohol pad and gauze or a cotton ball or something like that. And then obviously your child's, which this is what I'll give it the injection in. And I was just thinking these cute bags that we got are not only good for like a lunchbox, but also good to kind of make your Solu-Cortef emergency injection kit and keep it in there. So go. All right, so we have all our supplies. I think we're ready. We should always wash our hands. And I realized that that's even in here too. So let's do that to be consistent. And also remember to breathe, because this obviously is presumably going to be in a stressful situation. Even though it's incredibly important to give this medication, you do have a second, like you have to breathe yourself in order to help your child. So, all right, so washing our hands. All right, so we're going to take our active vial and we're going to press down on it, and that's going to suspend this plunger into the powder. So you now, if you can see, the plunger is in the bottom of the vial, and then you just swirl, and it should be clear once the powder is reconstituted in the saline. All right. There is a little cap on the top of this that you have to remove. So you remove that, and then you go ahead and clean the top of it. All right, so now you're going to prep your needle. You have your syringe here. I have my needle here. And this needle is a little bit bigger than the one we usually prescribe, so don't freak out. But it is bigger than a growth hormone needle because it's supposed to go into the muscle. This is a 21 gauge, and we usually prescribe a 23 gauge, so it's pretty close. All right, so you have your syringe, and then you have your needle, and you're going to screw your needle into your syringe. And then take off the step. All right, so we have this here. We're going to insert the needle into right in the middle. There's an area. All right. And then flip it under. And you're going to pull out your dose. All right. So most kids who are over 10 years old, their dose will be 100 milligrams, which is gonna just get rid of this bubble. All right. Which is 2 milliliters on this. Okay. Your doctor may prescribe a 50 milligram dose, or they may prescribe, if you have a really small baby, 25 milligram dose. And so that would be 1 milliliter and half a milliliter. So obviously my official recommendation is to draw up the correct dose. I will say if it's an emergency situation and you give a little bit more than what it calls for, probably nothing will happen. It's best to get this medicine in. So try not to stress too much. So we have our full dose here. Bubbles are always kind of tricky, so you can just saw me struggling with one. Obviously, the biggest thing is if there's a little bubble, that's fine. If there's a big bubble, that could affect the dose. So I usually flick my bubbles to the top and then just pour it out a little bit, but if 2 small bubbles, that I'm gonna let slide. So then we're gonna recap. And we can take our other alcohol pad and we're gonna prep our patient or child. The best place to give the injection is mid anterior thigh. So the mid front of the thigh is where the quadricep muscle is the biggest. And so I would recommend that place in everyone. So you're gonna clean the area and then uncap your needle because you're ready now. You're gonna press right 90-degree angle into the skin like a dart, and then press the plunger to give the medication, and then pull out. All right. All right, so that was kind of it was far away. Do people want to come up and want to do again? We could even have like someone try it if they want to do. I have other things to practice on, so looks like we have 7 minutes or so. Right, okay? Yeah, so anyone wants to probably. Oh, awesome. Yay. All right. Stuff out of here. Awesome. All right, you want to sit here? I think it's easier if you sit. All right, so let's get you 23 gauge. So that's actually the size of the needle we usually prescribe.
Okay.
And that's the syringe. This is the alcohol pad. And then this is for after you give it, if there's blood, you
Right, right.
All right, so I think all right, so awesome. Oh, yay. Okay. All right. What? Yay. Okay. All right. So first, let's have you wash your hands. Pretend it's
Yeah, sure.
and having a large audience. It's not quite the same as an emergency situation, but it's still pressure. So the easiest that we can replicate that.
That's fair. That's fair.
All right.
Okay.
So
Syringe. Things are like when you really want to open it, it's like so hard to open.
yeah, I know. I know, right?
Okay. And then should I take this off first?
Yeah, so first you should deploy it. So the powder's the medicine
Oh,
there,
right.
and then that's the liquid that you want to get into the powder.
Right.
So you got to press, it's really kind of hard to press down. Perfect. All right, and then now just swirl it. And
So some little
yeah, some little specks.
bits. Okay, I think it's all started.
Awesome.
And
All right, so yeah, so this is a little, I'll show you like the one I used. That's where you put the needle, so you have to take that cap off.
oh, okay, like
Yeah,
this.
Yeah. Yeah, I had to kind of use my nail, yeah.
Mm.
Perfect, perfect. And then you clean the top. All right, so you have to see that little bullseye right there. You put the
Mhm.
needle right in there.
And how much?
So let's say 2 milliliters, because that's every kid over 10.
Okay.
You get
Oh,
2
okay.
milliliters. So, yeah. Yeah. No, but this is
Yeah.
the only way the bubbles. Oh, I know, I was gonna say, great technique with the bringing in the, yeah, yeah.
No, like it's like sitting around.
Yeah. Yeah, because this is a full dose, so.
Okay. Well, okay, that's good enough.
Yeah, in terms of the finely tuning, very different than insulin in terms of
Yeah, right.
getting that
right.
fine tuned dose in, yeah. I'll clean your patient for you.
Okay, thanks. I guess that's good enough. There's a big bubble, but great.
Good job.
Thank you.
All right, thank you, everyone.